Parkes-Weber syndrome. Parkes-Weber syndrome is an uncommon congenital vascular malformation. It was first described in 1907 by British dermatologist Frederick Parkes-Weber. It is only found in about 0.3% of the world population. The characteristics of Parkes-Weber syndrome. It is characterized by the venous malformation, cutaneous capillary malformation, and lymphatic malformation found in Klippel-Trenaunay-Weber syndrome, along with arteriovenous malformation. It also can include fistulas occurring with skeletal or soft tissue hypertrophy. The syndrome can affect multiple limbs, the trunk, and the head. The body's lower extremities are most commonly affected. Symptoms: capillary malformations. The most common effect of Parkes-Weber syndrome is capillary malformation, which are known as port wine stains. They first appears as a red macular stain of the skin that darkens over the years. Capillary malformations are flat, cutaneous, slow-flowing lesions that are made of venous channels that are dilated or are increased in number. Vascular anomalies. Both arteriovenous malformations and arteriovenous fistulas are fast-flowing vascular anomalies. They can be in the skin, muscle, bone, internal organs, and brain. Arteriovenous malformations and arteriovenous fistulas can cause bleeding, congestive heart failure, or neurological consequences. Arteriovenous fistulas specifically cause the high-output cardiac failure. Arteriovenous malformations originate while going through embryogenesis, and they are rarely found to regress spontaneously. This complication can make Parkes-Weber syndrome a life-threatening condition.
Hyperpulsatile fistula with outflow stenosis. A normal fistula is soft, incompressible, and has a soft, continuous thrill. With outflow stenosis, the fistula becomes hyperpulsatile and firm. As you can see in this animation clip, the radiocephalic fistula with inflow through the radial artery, outflow through the cephalic vein. The first part of the animation shows the continuous soft pulse all along the outflow cephalic vein. The second part of the animation will show stenosis in the outflow tract, and distal to the stenosis, the segment of the fistula becomes hyperpulsatile. This distal segment is firm, and as you can see, has a very strong pulse because of the transmitted arterial pressure through the anastomosis. Again, the panel on the left shows normal, soft pulsations transmitted all along the outflow tract. The panel on the right shows stenosis, and distal to the stenosis, the segment is hyperpulsatile.
Causes: mutations on the RISA1 gene located on chromosome 5 cause Parkes-Weber syndrome. In normal circumstances, this gene mediates cellular growth, differentiation, and proliferation from various receptor tyrosine kinases on cell surface. Vascular anomalies are associated with this gene losing its function. The gene is spread through inheritance. Recently, patterns of autosomal dominance have been reported, which means the gene only needs to be from one parent in order to be passed on. Parkes-Weber syndrome affects both males and females equally, and no racial predominance has been found. Treatment: prevention of trauma. Lifestyle modification occurs with sporting activity, since trauma may worsen the arteriovenous fistulas. First aid advice for patients if they have lesions prone to bleeding, apply ferropression and seek medical help. Elastic surgery to reduce lymphedema and vascular steel. Avoid laser treatment of the skin lesion. This can worsen the shooting through arteriovenous fistulas. Complication: skin. Cosmetic problems with the appearance of the lesion. Some skin lesions may bleed easily on minor trauma. Patient needs advice about first aid. Ischemic ulcers distal to the lesion. Recurrent skin infection due to lymphedema.
Ultrasound showed an arterial. Hi, I'm Dr. Tom McClellan. I wanted to share a really interesting case with you that I recently performed, which was resection of an AV fistula of the radial artery. This patient had had a coronary intervention through a radial artery approach about 3 months prior to admission. Over that 3 months, she had started to develop pain in her distal wrist. She started to develop some paresthesias of her median nerve distribution, and this had been enlarging about 2 weeks or 3 weeks before admission to the hospital. And this is about 3 months after cardiac catheterization. Ultrasound, duplex ultrasound, showed an arteriovenous fistula between the radial artery, distal radial artery, and the vena comitans. This area was quite large. It was about 1.5 to 2 centimeters in diameter, and you could feel a topical thrill over this mass, which was very superficial. It was determined to take her to the operating room and to treat this with resection and reanastomosis. And since then, the patient's completely resolved her issues, the paresthesias have gone away, and she's returned to activities of daily living. I wanted to share this case with you, and I hope you find it interesting and educational, and thank you so much for watching. Here's a duplex ultrasound of the distal radial artery showing the arteriovenous malformation. You can see it here in the confluence of color. Here's the radial artery and AV fistula, vena comitans dissected free in the wrist. And you can see the AV fistula right in the middle of the screen, and the enlarged, tortuous nature of the ulnar vena comitans.
Thank you.